Hi everyone. Hopefully we started recording here. And this is a review of ABGs. I know you've had an introduction to this in a previous class, but it's one of those things that's, I don't know, kind of hard to get in your head. So I thought I would provide a video here that reviews it once again for you, and it could be useful. So I'm going to share my screen and pull up the lecture. Okay. Arterial blood vessels. By itself, it might not be a useful tool. It is a lab draw. You have to actually get blood out of the artery, so it's not as easy to get this since most lab draws are venous, which is easier to achieve. But certainly ABGs, there is the average and there's a norm, right? But there are certain patients that compensate quite nicely and their gases are terrible, but they're acceptable. So it's only useful if you can see the trends and you know the patient's history and other findings that may go along with it. For example, COPD. A COPD may naturally have an increase, not natural, but because of the illness, have an increased CO2. So if you see this lab work and you're like, oh, PCO2 should be 37 to 47 and it's 755, and he looks comfortable, you're probably not setting off alarms. Or the very shocking ABGs to look at are the child with congenital heart defect. When you look at a kid with a congenital heart defect ABG, you're like, holy moly, because I would be dead. Those ABGs are at least coding. If the pH is normal, okay, so it's compensated to normal, and at least the PO2 is higher than the PCO2, sometimes you're like high-fiving, woohoo! You'll see a 69 and a 55, you're like, wow, that's good, which of course is not good in normal instances. It's an arterial puncture. Most of the time you'll see in the hospital, they'll go to the wrist and withdraw it from there, but it can be done from the antecubital, it can be done from the femoral, or you may have a line in, an IV line that's actually in the artery, which we're going to talk about in another class, and you can draw from that. So when you do draw this lab work, it's important that you'll see them draw it in the ABG tube and shove it in a glass of ice and then send it to the lab. The reason is the PO2 levels will decrease if it's not kept on ice. And then you have an artificial low PO2, which doesn't match your patient. And it's a heparinized syringe because you don't want the blood to clot in the artery. Okay. Oh, hang on. Slideshow. Oh, they didn't look right there. That's a clear picture for you guys. All right. So, what are the components of oxygenation? Okay. Well, PaO2 or PO2, you may see it written either way. Normal is 80 to 100. So, how do I remember that? Well, we know glucose should be about 88. So, right around that range, right, is where we expect normal. Some of the elderly may hang out at the 60 to 80 range, and yet they're not short of breath and they look okay. If it's low from quote unquote normal, then they're by definition hypoxia, or they have hypoxemia, or they're hypoxic. Any of those work. Play with your Latin words, ladies and gentlemen. So what are the signs and symptoms if I'm hypoxic or my oxygen level's low? Dyspnea, tachypnea, short of breath, breathing fast. You may see them using their accessory muscles, kind of a bounce to their breathing. Tachycardia, because my body senses if there's not enough oxygen to get out in the tissue, and I'm already breathing fast, then another option is to pump it around more, right, to try and compensate. You'll definitely see that if anybody's been snow skiing or you're hiking up the mountains, you're like, why is my heart so fast and I'm working so hard? You're compensating, okay? Now, early you can get tachycardia. If they get stressed or they're not tolerating the hypoxia, then you may start seeing some arrhythmias and the sympathetic kicks in. So you can see hypertension early because the body's, whoa, we got to fight, something's going on. And if they start what we call decompensating or failing, then you might see hypotension, and that's more of a late sign. They're actually getting in trouble. So the partial pressure of oxygen, or PaO2, is actually the oxygen dissolved in the arterial blood. That's what you're actually measuring there. And so what else are we looking for? Well, anxiety and restlessness. We talked about this under the earlier respiratory lecture. In other words, if I'm short of breath, just remember that person's swimming that starts to drown, or your friend that got held underwater too long. They get anxious, they'll get wild because you're fighting for air, so to speak. You can just be mildly restless on a person that's in not that great a shape. Can be confusion, a slight stupor state, and certainly fatigue, as you all felt if you've ever tried to hike up the mountains when you're at a very high elevation. Cyanosis is that kind of grayish blue look. It's most easily to see in the lips, the palms of the hands, the skin tone in general, or general pallor. I don't know if any of you guys have already had OB, but you could see that OB patient that you're getting out of bed the day after and her hemoglobin's too low, and you can just see that pasty look on her. And actually, if the person's level of cyanosis, it's generally considered a late sign. Diaphoresis, they'll kick in because that's a sympathetic kicking in, and cool and clammy skin. So all things you would look for a low PO2. A little bit about the pH. This is important. This tells you whether they're, in a lot of ways, tolerating what they have. Can they buffer for it? Can they keep their acid-base balance within the range despite numbers pulling in different directions? So it's a concentration of hydrogen ions, H+, if you remember from organic chem. I actually liked organic chem. Call me sick, but it was way more fun than general chem, I thought. My teacher was just great. We made toothpaste, and we did a little study testing the different types of soaps, dishwashing or clothes washing soap, and which one broke up grease and dirt the best. It was really fun. Anyway, it was like doing puzzles. I like doing puzzles. Anyway, so normal 7.35 to 7.45. Now, memorize a number that works in your head. Depending on the lab, one hospital might say 3.4 to 4.4. You know, the numbers may be slightly off, but they're all going to be right around this range. I like to remember this because I can remember 37 to 47 for hematocrit and 3.35 to 0.45 for pH. So they're almost the same. So anyway, if the pH decreases, the number drops below 0.35, then by definition, there are more hydrogen ions. The patient becomes acidotic. So look at the picture down here. So decreased number is more acidotic, a smaller decimal number. And I like this picture because it gives you, okay, we know, just kind of remember, you can just remember 7.4, that's right, boom, that's where it should be. If somebody's not breathing well, they had too much anesthesia, they're not waking up from their anesthesia, you might see it going below 7.3. Now, 6.8 is generally, this is a rest situation. Somebody's gotten too acidic, they're coding. And most of the events you're gonna have in the hospital setting are severe acidosis. But it doesn't mean somebody can't be alkalotic, okay? Because we artificially cause problems, overbagging somebody, giving too much bicarb. So 7.5, you're starting to, you know, head in the wrong direction. 8, you know, this is somebody that is probably going to code. So if the level increases, the pH gets higher, you're alkalotic, and if pH gets lower, you're acidotic. So we're taking each little component of the arterial blood gas. Now, PaCO2. This is the partial pressure of arterial carbon dioxide that's actually dissolved in your arterial plasma, and you'll see mostly just written CO2. It's another easy number to remember because it's like the pH and it's like the hematocrit, 35 to 45. And if it decreases, the number's dropping. Now, this is hard because the pH gets lower, it's acidotic. But this one drops their respiratory alkalosis, okay? I'm trying to think of the story to explain that one. And if the PCO2 is greater than the respiratory acidosis, so CO2 is a dangerous state to be in. And it's generally somebody that's not breathing good enough, okay? So the way to remember this is saying, if I'm breathing too fast, or hyperventilating in the sac, you know, like the cartoon character, they're panicking and they give them a sac to breathe in, right? So they're not blowing off too much CO2. If I blow off too much CO2, the number is going to drop, and I'm alkalotic. I'm blowing off CO2, so I'm alkalotic, because we know not breathing enough, just laying there, I did a bunch of drugs and I'm not breathing, I'm going to get acidotic. So breathing too much, blowing off too much CO2 makes me alkalotic. That's the easiest way to remember it. Always think about blowing off CO2, okay? The panicky person that's breathing too fast, or somebody's at the ventilator too high. So PCO2, if it's a bigger number, because it's building up, the CO2 is building up in your bloodstream because you're not exhaling it properly, then you're acidotic. So the pH gives you an essence of how your metabolic and respiratory status can buffer and keep your acid-base balance where it belongs. PO2 is a measurement of your lung capability, and PaCO2 is an indication of your lung ability to regulate. So if you hypoventilate, you're not breathing enough, you're going to retain CO2, you're going to get acidotic, okay? If you hyperventilate, you're blowing off CO2. Okay? So another component is sodium bicarb. So CO2 is an indication, so think of pH as just telling us how's it going. PO2 it's a side thing. What's our oxygen carrying capabilities? CO2 tells you the respiratory capability. Bicarb, HCO3, gives you a hint of the ability for the kidneys to buffer. How are you metabolically able to buffer, okay? So HCO3 is a base that buffers acids in the body. So if I get too acidic, my kidneys can try and help me by compensating. So I've got two ends of the spectrum trying to help balance where I stay and have a proper pH, okay? So it reflects your metabolic system. It's regulated by the kidneys. And if it's levels greater than 26, your metabolic, back up, move up, I won't go there. Yeah, okay, so if it's regulated by the kidneys, we'll excrete bicarb with respiration. Then I become alkalotic. So the PCO2 is too high. Okay. We'll retain bicarb with respiration, then I can be acidotic. So the kidneys are trying to buffer for what the lungs are doing if either of them is out of whack. If that makes sense, I hope. The normal is 22 to 26. I don't know how to remember this number. It's a lower number. You could say it's about half of what the CO2, boom, was the 40-ish range. And you can see this is in the 20-ish range. So that's a way to remember, it's like half, okay? So normal is 22 to 26. If the number gets higher, I'm alkalotic. Numbers higher, bicarbs building, I'm alkalotic. If it's low, I'm acidotic, metabolic acidosis. So less than 22 is by definition metabolic acidosis. Okay, so base excess or base deficit. Depending on where you work, the lab may or may not come up with this number. If you're in a cardiac center where they do open heart surgery, they share this number on the lab values. So don't be surprised if you see it. Would state boards do this? I don't know. They're different with like the basic ABGs. I don't know that they would include this. But it reflects the sum of all the buffer bases. Okay. So it's a good indication of metabolic acidosis. So we worry when somebody's had open heart surgery, they're in a very low perfusion state when they go on bypass. And we'll get to the cardiac lecture in another week or two. I'm just introducing it here. And so you're not perfusing well out to the periphery, even though you've got good reasonable flow to the brain, lactic acid will build up. Okay, so when your blood pressure might be fine, everything's fine, but you're very cold and clamped down, so not good peripheral circulation. As you warm the person up, they will flush out that periphery that was cold and clamped down, and they'll obviously lactic acid built up, so it can flush into the bloodstream. So it's an important extra number to look at when you're worried about perfusion and perfusion deficits. Okay, so the normal base range for the base deficits is -2 to 2. It's kind of easy to remember that. And generally it's a range from 0 to 10. So think of the middle of the scale for the pH middle, -2, below that you can look to acidotic, +2, you get to alkalotic. So the base deficit is with metabolic acidosis. You've used up your body buffers, is what it's kind of telling you. I can't get more help. Base excess, total buffers are increasing, then I would end up being more alkalotic, metabolic alkalosis. It's an extra value to consider when you're looking at the ABGs. It's a good indication of metabolic acidosis, which I told you we worry about in the cardiac patients, and will give you a hint on their ability to compensate, which we'll talk about in a minute. Your lungs regulate the CO2, and the kidneys regulate the bicarb, which are important features to remember. Okay, so let's talk about it a little more. So if I have a patient that is just purely respiratory acidosis, okay, it's increased retained CO2, probably due to poor ventilation, hypoventilation. They're not getting big enough or frequent enough or strong enough breaths. Okay. Respiratory alkalosis, that's the only problem. Respiratory alkalosis would be a low CO2. Almost always it's just some sort of version of hyperventilation. It's coming from the lungs, right? Acidosis, alkalosis, anything with a PCO2, it's a lung issue, right? So this person is a lady panicking and breathing too fast, okay? Metabolic alkalosis, coming from the kidneys, coming from the metabolic state, increased bicarb, HCO3, and you're going up higher on the base excess. So you lose acids or have an excess in base. You're getting +2. Okay, you're losing acids. Increase bicarb. Okay, HCO3 is bicarb. Metabolic acidosis is accumulated of fixed acids. So again, so the lungs can be doing whatever they're doing, but metabolically it's building up. You end up with a decreased bicarb and a negative base excess. So if we try and, this is one we worry about in a shock patient, in a poor perfused patient, we're worried about hitting down this D here, the metabolic acidosis train. Okay, so what about compensation? Well, normalization of pH happens with acid-base imbalances, hopefully, physiologically. The system's not primarily affected, returns of pH to normal. So when I'm looking at so we just said a second ago, pure respiratory acidosis, pure respiratory alkalosis, if those were the only issues, the lab value would have that one issue that would be off. Okay? And those are the easy ones. The STEM boards would probably ask you this easy. They're definitely not going to ask you mixed gas. I'm not even going to mixed, if I can say it, mixed gases. You will see those in the hospital a lot, though. There's more than one thing going on, especially in a severely ill individual. But what the body does is try to compensate. So let's say I'm out of it, I had too many drugs, I'm not breathing good enough, then my kidneys will try to buffer for the acid building up because I'm not breathing well, and vice versa. So normalization of pH with acid-base imbalance can occur with your body's ability to buffer one way or another. The system not primarily affected returns the pH to normal. So if I'm looking at a lab value and the pH is normal, but my CO2 and my PO2 and my bicarb are off, then whoever is worse is put the CO2, PO2 aside, who's ever worse, the CO2 or the bicarb, is the lead issue. The other one's shifting to try to compensate for that one. Does that make sense? So I'm looking at the lab, pH is normal, or it's getting close to normal, which you get partial compensation. Then if whoever's the worst, he's the bad guy. He's the insulting agent, the other one's trying to buffer. Now, you can have mixed gases where both of them are problematic in a patient. Kidney failure and I'm not breathing well. So if compensation can be partial or complete, the kidneys react with respiratory abnormalities by excreting more acids, H, and retaining bicarb. Okay, so it tries to balance. And the lungs compensate for metabolic issues as well. So it can be partial or complete. Partial completion is if the compensation has occurred, but the pH is still abnormal. So you can see both of them are off, and the pH is not quite to normal, but better than those numbers should tell you it is. With metabolic acidosis, there's an increased depth and rate of breathing to blow off CO2. So if I got metabolic acidosis, you can see the person breathing harder in an attempt to buffer, right, to blow off CO2 to make you're physiologically less acid overall. In metabolic alkalosis, the rate and depth of breathing may decrease to try to retain acid. So so what you're seeing sometimes respiratory-wise could be because of metabolic issue, not necessarily a lung issue. Kidneys respond to respiratory acidosis by excreting the excess hydrogen, acids, and retaining bicarb. The kidneys excrete bicarb with respiratory alkalosis and retain bicarb with respiratory acidosis. So, more details. Respiratory acidosis, retained CO2. Who gets this? What happens? Who's the likely guys? Get my tea here. Well, if there's brainstem suppression, okay, they've had a head injury. They're not going to potentially have the drive to breathe like they should. Anesthesia, we block their ability to breathe. Okay. Narcotics, well, yeah, that's a very common problem. So when I was younger in nursing, we all knew about Narcan, but now it's gotten so bad with the dingbats out there doing drugs that your average IMSA guy, ambulance guy, has to carry Narcan around with them. I guess in some places they even give it to the drug addicts, like really, and don't get me started. But Narcan's an interesting drug because it blocks the opiate and it used it a few times to try and get a person to start breathing, and it works fast. And you may have to scrape them off the ceiling because they'll wake up so severely from their anesthesia. Or they could have poor chest expansion. Let's say they have multiple rib fractures and they're not taking good breaths. They have some sort of airway obstruction, either blockage or a lot of secretions or swelling. And they're just not hypoventilation for some reason, other reason, and underlying lung disease. All common reasons for respiratory acidosis. Metabolic acidosis, okay, is the overproduction of hydrogen ions. You're not getting rid of enough acid, so the kidneys should be balancing it, right, and throwing out the hydrogen, excess hydrogen. Or you don't have enough base left to offset the normal amount of acids that occur anyway. So if we rapidly correct hypercapnia, sometimes it can shift them in the wrong direction. Back to the drug overdose people, they're intaking acids, then they end up with and of course renal failure, and they're not able to excrete it. The excess breakdown of fatty acids, keto acids, and we talk about it, ketoacidosis. So it's actually not terribly good for your kidneys to go on one of those no-fat starving diets because you literally break it down. Lactic acid building up back to the shock state or some severe heart, let's say cardiogenic shock, not perfusing well out to the tissue, so lactic acid's building up. And diabetic ketoacidosis. very common issues. Now, if I have renal tubular acidosis and severe diarrhea, because I can lose a lot of acid by pooping them out, and then the kidneys try to balance that, lower bicarb, so not enough base. And that would help to that would naturally help to neutralize the acid in the blood. Certainly poisoning by aspirin or antifreeze. Evidently antifreeze is a problem because I obviously never tasted it, but they say it doesn't taste bad. So it's like a dangerous thing to have in your garage because your dogs might look it up and because it tastes evidently sweet. Respiratory alkalosis. Loss of carbon dioxide, CO2. So back to the hyperventilating person, the stressed person. All of us have had it up when we're snow skiing, especially the first couple of days. You're like, why is this so much work just to go 10 feet back up with your skis on? You know, you lose your pole and you're trying to get sidestep back up the hill. I'm in a shock state, high fever state, if there's CNS damage, sometimes with a lesion, and in a pain scenario. You're avoiding, you may hurt, but you're taking a lot of rest, a lot of small fast rest. Metabolic alkalosis is the loss of acids or excess base. So I could take too many antacids. Citrate excess. So when we give blood transfusions, they put citrate in there. I don't know why. I think it keeps it from coagulating, or is it as a preservative? I'm pretty sure. In blood transfusions. So, which is fine if you're just getting 1 unit of blood or 2 units of blood, but in a massive trauma patient, they may get 10, 13 units of blood, and at the same time they're getting citrate. So it can make you metabolic alkalosis. Now, this is interesting. That same trauma patient should be acidotic, right? Because they're not perfusing well because they don't have enough blood circulating around. So you can see how you get mixed gases. Not vomiting and having a chronic nasogastric tube can also cause it. Excess cortisol, steroids, hypoaldosteronism, high diuretics. So if somebody's chronically taking large doses of Lasix, they may be metabolically alkalotic. We already said NG section. So it's one of the things to look at the ABGs and you say, oh, why is the alkalotic? I get the Lasix all the time. So combined issues or mixed gases can occur, especially have multiple problems affecting the other, which I'm pretty sure nobody on state board is going to expect you to get that. Because there's no way in a quick question you can have the giant scenario of a complicated patient. But in the hospital setting, you consider that, we're trying to leave him off the ventilator, but he's also getting a lot of diuretics. Why is this crisscrossing, so to speak, in your lab values? I think those are the biggies on that. Okay. All right, so here's a nice little one-pager you can pull out and stick in your pocket if you feel the need to, like in the hospital setting, to say, okay, what am I looking at? Up at the top here, here's your norms, 7.5, 35 to 45, which helps me remember CO2, 35 to 45. Remember, labs might, whatever hospital, the lab numbers might be slightly off from there. Bicarb, 22 to 29. And PO2, 80 to 100, that's a side spot. And the base excess should be somewhere between -2 and -1. Okay, or +2. Just kind of want to say that, +2 to -2. So these are the steps to evaluate a blood gas. Step 1, what's the pH? Is the pH okay? So mid-range is 7.4, and that helps you know if it's acceptable, and then you start identifying the process and control. So then you evaluate ventilation, side thing, okay? Is their PCO2 is increased, then they're acidotic. PCO2 increased. This is the person that's kind of out of it, not breathing well, right? So CO2 is building up. If it's decreased, they may be hyperventilating, they're alkalotic, okay? Now, if you're evaluating the metabolic state, the bicarb and the base excess, increase is metabolic alkalosis. Remember what was that up here? Bicarb, 22, 26, 22, 29, somewhere in that range. depending on the book you read in the lab you're looking at. Decreased is metabolic acidosis. Okay? So what we're trying to do is identify the primary disorder. So if it was just one thing, you can look at these above here. But more than one thing going on. So if the pH is abnormal, acid-base component most consistent with the pH is the primary problem. So if I'm slightly acidotic, and you'll see the one that's worse is generally the lead problem. And the other one's trying to pull that one back to normal by buffering. Okay? So if the pH is normal, look at whatever component is most deviant. So if the pH is abnormal, acid-base component most consistent with the pH is the primary problem. You're going to have multiple problems, right? pH is acidotic, it's abnormal. Who fits that the best? That's the guy. Okay? But if pH is normal because it's compensated, then you look at whatever one, because they're both off. Who's the worse off? He's the lead guy. Okay, so he's the underlying issue. The other guy's trying to buffer. Okay? Then you determine the presence of compensation as an adjusting normal pH. There's a presence of CO2, presence of CO2 and bicarb are abnormal, but in opposite directions. If there's absent compensation, CO2 and bicarb, one is normal, one is abnormal. If he's normal, he's not buffering, right? So it's still off. This guy's off by himself. Okay? Then you evaluate CO2 on the side, because you can have a mixed disorder with more than one problem, and you'll have trouble differentiating the compensation. So it's very important to do this at the bedside in reality. For the sake of a test, we'll give you, I might give you a very short scenario. Keep it simple just so you get concepts. But in reality, you may have a patient that's got kidney disease and he's got COPD, and so now the story gets more complicated. So if the PCO2, excuse me, it's the only problem, then it's the primary problem when you're looking at ABG, for example. I'm certainly looking at oxidation on the side. It's a significant problem if it's under 60. And then you obviously consider the amount of support is required as well. We talked about this earlier. Actually, whenever you're watching this, it's under the respiratory lecture. So if PCO2 is low, okay, if it's, let's say it's normal, low normal, like 85 or 83 or whatever number in there. You're like, oh, pat yourself on the back. But if he's on 100% oxygen, that ain't so great. But if he's on room air, that's not so bad. So you also consider what's the level of support I'm providing to achieve that oxygenation status. Okay. And again, there could be mixed gases. So compensation is a system opposite the primary disorder that tries to compensate. Absent compensation, if the system opposite primary disorder is still normal. So there's no compensation going on. Partial, if the pH is still abnormal, but compensation has occurred. Okay, so you're looking at the pH, who's the problem? Is there only one thing showing a problem, or both, and who's the worst? Okay, so I'm just going to use some samples here to look.
Just a sec. Sorry.
Stop. Who let Siri in my phone? I apologize. Okay, so elderly patient in the ER. Okay, things go off in your head. Age is really important. In clinical scenario, the first thing you tell me, and please, if you don't have me as your instructor, first thing is this is Mrs. So-and-so in room such and such. She's a 75-year-old. You say the age, and you get a whole versus a 32-year-old. You told me something completely different right there. Very important. Anyway, elderly patient in the emergency room, obtundant. Obtundant is that kind of adamant person, difficult to arouse. If they do arouse, they're not waking up easily. With deep respiratory drive at a rate of 36. So these long, sort of protracted, rapid breaths. And then you got ABGs on room air. We've done nothing yet. Okay, so whoa, pH is acidotic, right? And there's a hint. You can look over here on the side. I gave you the answer. Okay, it's not 3.5. PCO2, whoa, blowing it off, decreased respiratory alkalosis. So if that's all we knew, if we didn't have any other numbers, we'd say, oh yeah, respiratory alkalosis. Now, bicarb is decreased, saying it's metabolic acidosis because it's less than like 22. Okay? Base excess is way over on the -10 side. Okay? But by itself, the PTO is fine. So O2 is getting across. La la, happy, getting picked up. Just taking all those big, deep, frequent breaths. Okay? But the acid base balance is terrible. The PCO2 has been blown off. But we're off here too, the bicarb, metabolic acidosis. Okay, so metabolic acidosis with an attempt to compensation, respiratory alkalosis. So you'd say it's a partial compensation because we're not at the pH we should be at, but we do have adequate oxygenation, so you report that as a side factor. Okay, so let me give you another one here. Post-op surgical patient. Well, any post-op surgical patient, we know they had anesthesia. So we're worried they need to wake up and start breathing reasonable on their own, right? So the pH is acidotic here. Well, that's not good. Okay. PCO2 is 80. Hitting the low side. And again, if this was the only problem, you'd say it's respiratory acidosis, right? And sure enough, the bicarb's normal. So if the bicarb's normal, the pH is still off, then the PCO2 is increased. We would say respiratory acidosis. Okay? And on top of that, the PO2 is not good. This person's not, they need to wake up and start taking some deep breaths. You go in there, Mr. So-and-so, wake up, take some deep breaths. You know, you're sometimes go in there and take 1 or 2 breaths and they slack back off. So you got to sit them up a little bit, you got to get them going. Okay, funniest story. I can't tell you the funny story on tape. Anyway, respiratory acidosis without compensation with hypoxia. Okay, so you're not seeing the bicarb buffering away here. So now we have a post-op surgical patient, and this person's complaining of shortness of breath and weakness. You've got a nasogastric tube in, and their abdomen's distended. So what am I looking at? Well, my pH is normal. Woohoo! Time for lunch. Taking off. We don't mind that at all. PCO2's normal. 37 to 47. Okay, not 40, right? So it's okay. Oh, what's this? Metabolic alkalosis, 34, right? We don't want really more than the range. And so put another range in here, 22, 29. That depends on the lab, right? Or the textbook. So it's above my 20-somethings. I don't like that. Okay. Base excess is 7, so we're in the plus category. PO2 is okay, 83. Oxygenation is occurring. Okay, stats are 93. But metabolically, this isn't so great. Okay, so I have metabolic alkalosis. There's no compensation because you don't see any shifting in the other one to try. There's no buffering going on over here, right? And with borderline hypoxia, because there's borderline. Now, this is only 83. Stats are okay. If I just did a stat, I'd be patting myself off on the back and walking off. It's 93. Well, 94 is better, but either way, I wouldn't be in a panic because this is not a good blood gas. All right, here's one more. Oh, more. I got 2 more. Anyway, pH is 7.40. Okay, like that, right? Right on target. Happy guy. PCO2 is 59. Oh, dear. Okay. Increased respiratory acidosis, right? If the CO2 goes up, he's not able to blow it off. He's retaining CO2, so it's respiratory acidosis. Bicarb, 29. Yeah, it's creeping on the edge of abnormal, but it's technically normal, depending on the lab book you look at. Base excess, okay. Yeah, compensation, we're right, kind of where we should be for buffering. Okay. PO2, ooh, no, not so great. 79. The SAT's only showing a 92 with this. So again, if we know a lot more once we got the ABG here. It's 92, you're like, it's on the low side, but it's still okay. It's in the 90s, right? So we're going to say respiratory acidosis. CO2 is your primary problem. Bicarb is sort of heading off to try to help, but it's not. Compensating. because the pH is normal, even though this PCO2 is terrible. Now, if it's compensated, this guy shifted just enough to pull it over with poor oxygenation. Okay, here's another one. pH 7.51. Okay, just pure. That's all we know. They're alkaline, metabolically alkaline. That's all we know. Maybe respiratory. What do we know? And then we move on. PCO2 30. Decrease. So by itself, this is respiratory alkalosis. Okay. So maybe they're blowing, the CO2 is low, right? So blowing it off, creating that alkali pH. But then we look at the bicarb, in the 20s, okay? Hanging right there in mid-range for me, so that's normal. It's excess, normal. Now this was great. It's saturation fine, oxygen level's good. So I maybe overkill, 98% sat. So by itself, the only guy that's a problem is the PCO2 because you're blowing it off and it's created alkalosis. So we need to calm this person down. Somehow slow the respiratory rate. Okay, so I hope this was a reasonable overview for you guys and makes sense. And it's a good one to kind of practice. Once you get it in your head, you can look at the gas and go, oh, but it takes a little practice. Okay, hope this helped. I'm going to quit sharing and see you guys later. Bye.